So we're going to move on to hindfoot fractures. So Dr. Al is going to come up and talk to us about calc fractures and talus fractures.
Good morning. I'm from Dallas, Texas. Good to be here. I left it was 95 degrees. I'm not really a big fan of the heat. I don't have any disclosures, unfortunately, but if anyone wants to pay me for talking or doing something, I'm more than happy to be a consultant. First, we'll talk about talus fractures, then we'll get to calcaneus fractures. Talus fractures are not as common as calcaneus fractures, and they're usually from high energy mechanism. This picture over here is at DFW Airport. This person didn't want to pay the toll, so they were going about 80 miles an hour on meth and alcohol, and they went up over these ramps instead of going through, went up and over, and ended up crashing. She didn't have a talus fracture, but this helps me to remember this is a high energy injury. The most common pattern is a talar neck fracture. You can also see some lower energy mechanism fractures that end up with a lateral process fracture. It's frequently called a snowboarder's fracture. But in general, you end up with talar neck or body fractures. Diagnostic imaging, you start off with at least an AP, mortise, and lateral of the ankle, and usually that's when the ER will pick them up. The foot x-rays can be useful as well because they look at the talonavicular joint. CT is common for body and lateral process patterns, and as you'll see with pilon fractures, there's themes, i.e. you'd rather have things reduced before getting a CT, and timing for operative intervention is usually dependent upon soft tissues. This is an x-ray, lateral view of the ankle, and the tibio-talar joint just doesn't look quite right. Here's the articular surface of the tibia, and this just isn't quite right. This would be a dislocation, and this is something that should be reduced urgently. I think before I trained, these would get taken to the ER, or excuse me, to the OR urgently, whether it was dislocated or not. And there was a study that showed that the if something is reduced, the timing to definitive operative intervention isn't quite as important as the quality of a reduction. So you may delay your open reduction internal fixation. Close management should be reserved for non-displaced fractures. Percutaneous fixation, I think some people will do for non-displaced fractures so that you can start to mobilize them earlier. Open reduction internal fixation is the kind of standard of care for displaced fractures. Typically 2 incisions, one medial, one lateral, to be able to see both sides of the talus, and you don't want to displace them in varus. Post-operatively, splint immobilization for the first 2 weeks to permit swelling, convert them to a cast for weeks 2 to 6, and then a boot at week 6 to 12. As you get x-rays, you should see some revascularization of the talus. The higher energy injury that you have, the higher incidence you have of avascular necrosis. However, even if they don't have the earlier signs of revascularization that you see in the dome of the talus, it's okay to initiate weight bearing at 12 weeks. That doesn't really change the course of the avascular necrosis. Complications, post-traumatic arthritis, the incidence of that is very high. I tell all my patients it's not just my poor surgical skills, but it's also the nature of the injury that they will get subtalar arthritis. Osteonecrosis, the rate of that increases based on the severity of the injury from 10% to almost 100%. So if you have what's called a Hawkins-4 talar fracture, where they have dislocations of the tibio-talar, subtalar, and talonavicular joints, the rate is 90 to 100%. Even with simple non-displaced fractures, some people have reported the risk of avascular necrosis to be 10%. Malunion and non-union can occur as with any other fracture. This picture here is a radiograph of avascular necrosis. You can see the bone in the proximal portion in the body is sclerotic and not normal. And that's because the blood flow has been interrupted, as this is one of the few bones in the body that has a retrograde blood supply. This is just a case example. This patient, motorcycle crash, had left ankle pain. It was a closed injury. You can see a lot of things going on here in the ankle. And this lateral is probably the more important one. Once again, this just isn't right. Doesn't take a genius to figure that one out. So even I could figure it out. Here's the lateral of the foot. This is looking at the talonavicular joint. That doesn't look quite right as well, so that's why I like to get an AP of the foot. Here's your talonavicular joint. That looks better there. But because of this patient having a subtalar dislocation, which the ER approved with a CT, tibial-talar, this patient was taken urgently to the OR, and we didn't do definitive fixation at that time. So it was pinned in place, had to open it to get it reduced, place an external fixator. That looks a lot more normal. We pinned the medial malleolus fracture in place. That was kind of nice. It can help see things. If you have a talar body fracture, then sometimes you create your own fracture with an osteotomy. So pinned in place, admitted, keep them elevated, and then you come back later during daylight hours, and you can do definitive fixation. Any questions on talus fractures?
You mentioned complications. It seems like a lot of times they have significant soft tissue injuries or pressure necrosis with their fractures and dislocations. You guys chose to take them to the operating room. Maybe you can comment on your soft tissue management.
Yeah, the reason that one went to the operating room is because the tibial-talar subluxation, dislocation, whatever you want to call it. I think anytime I see a talus fracture that's displaced, that gets admitted, elevated. And if you keep them elevated, I think as soon as the skin is wrinkleable, it's a lot easier to get to these, I think, sooner rather than later. But yeah, if the soft tissues aren't amenable, you have to wait. And that's why it was pinned in place and X-fixed so that we could, ensure that, once you could delay your ORIF until the soft tissues are amenable. But same theme as in pilon fractures. Bad idea to ever operate through fracture blisters.
Well, and a lot of us are rounding on these patients, and so one of the things that shows up later is those skin necrosis or that non-viable skin, or they start to slough in clinic. You see them and you think you did a great job, and then a week or two later, the skin envelope just falls apart over beautiful fixation. So it's just something I don't know, be really sensitive for.
Oh yeah, absolutely. Hindfoot fractures, pilon fractures, they will all defeat you because they're, most people don't sit with their ankle up. They're dependent and they swell up quick. Any other questions on talus fractures? Calcaneus fractures, on the flip side, they are more common than talus fractures. They're also high energy injuries. These can be associated with spine injuries. About 10% of patients with calcaneus fractures will also have a spine injury. The majority of those are in the lumbar spine. So just something to be cognizant of. If patients don't have any pain in the lumbar spine or in the spine, I usually don't get radiographic workups of that. Two main types, extra-articular, which may or may not need surgery. It's a kind of interesting dichotomy. Either they go to the OR urgently, or actually emergently as soon as possible, or they may not need surgery. The type that do need to go to the OR acutely, emergently, urgent, whatever term you want to use, semantics are the tongue types, which even though it's extra-articular, or can be extra-articular, they do need to go to the OR quickly because, once again, you get to the soft tissue injury that's associated with those. The intra-articular injuries, that's more when most important thing probably is waiting on the soft tissues to determine the time of operative intervention. The only way you can make a fracture worse is to get it infected, and that can happen if you operate on these too soon and you're not waiting until the skin is wrinkleable. In general, these are considered intra-articular fractures, and they do better with surgery, even our elderly patients. Diagnostic imaging begins with the AP mortis lateral of the ankle, which is how they're picked up a lot of times, where you get the 3 views of the foot. Harris axial views are important to look at the varus displacement, and then a CT is useful for intra-articular involvement. The other good thing about a CT is that there's a classification system known as the Sanders classification, and it can help you decide which treatment to give a patient. It's also prognostic. Once again, I don't know if you can stress this enough with pilon fractures, ankle fractures, or hindfoot fractures, but it's the timing of your open reduction and internal fixation is dependent on the soft tissue swelling. So if you have to wait 1 week, 2 weeks, 3 weeks, you have to wait until the skin is wrinkleable. And I think it depends on where you're at and what system you're in, but some people will admit all of these. Some people will send them home with a big yellow pillow or whatever you have at your institution, something to help keep their foot and ankle elevated. So treatment, there's been several good outcome studies showing that non-operative treatment is typically reserved for poor surgical candidates, non-displaced fractures, extra-articular fractures that are minimally displaced and that are not tongue type. Open reduction and internal fixation is more a question of how you get there. The tongue types, once again, as underlined, and can't stress this enough, tongue type fractures, urgent intervention. And if for some reason you don't have somebody that's comfortable with these types of fractures, or somebody that is willing to take care of these fractures, they need to be transferred immediately to another center. Another discussion point, lateral extensile approach versus the sinus tarsi approach versus percutaneous methods to reduce and fix these. The lateral extensile approach does have morbidity with it. It's the classic approach to calcaneus fractures, but in a series out of the institution I work at, there's a 20% infection rate of the wound. You get apical necrosis up to full flat blast. That might be because my hospital is right next door to the Salvation Army and the homeless shelter, and they may not have as good a resources to keep their foot elevated or whatnot, but either way, about 80% of those that get infected need a repeat trip to the operating room for further intervention. And the majority of those people that needed repeat intervention for surgical wound dehiscence were diabetics, smokers, and open fractures. So those are things that you may want to say, this may not be the best patient for a lateral extensile approach. The other thing on a CT, if you see a Sanders 3 or 4, then you may start thinking for immediate subtalar fusion rather than doing RAF and a delayed subtalar fusion, just to avoid the need for a second surgery. This is an X-ray of a tongue-type fracture. It's a 35-year-old construction worker. He fell off a ladder. It was only a 3-foot fall, and he had this X-ray. The problem was he went to 2 different ERs, and by the time he got to us, he was already sitting about 16 hours. So more important than the X-rays that they got in the ER is I get this picture at about 10 o'clock at night, and this guy had done it sometime early in the morning. And you can see, hopefully, I don't know how it projects down in the back of the room, but you get this pressure necrosis here on the posterior aspect of the heel. And this is how much it had worsened just from in the ER to about 30 minutes later when we had him in the OR prone. And this is the hardest part about managing this patient. He unfortunately developed some soft tissue breakdown. It didn't need surgical intervention, but we had to nurse his wound along for about 6 months. That's painful to be out of work because somebody couldn't get to your injury. It was during the daylight hours too. I don't know why he had to go to multiple different ERs, but that's something that you really got to be worried about in this injury. So he went back for limited open fixation, and he tried to stay away from that pressure necrosis area. On the flip side, you can get patients that have more of the joint involved, and these patients, you can wait for when you take them to the operating room, except for in this patient's case. He's 55-year-old. He's a 2-pack-a-day smoker, construction worker. He fell, and he had a lateral wound. A lot of times you'll see the wound on the medial side, but this guy was open laterally, so unfortunately we had to take him to the OR. CT. This is a CT scan. So we did a kind of a combination of things. Because it was open, we tried to limit our approach. He was open laterally, so we opened up that wound. Joint fixation, a small plate that we could fit through the sinus tarsi approach, and an X-fix on the medial side to try and keep his limb axis aligned. So that's not the typical fixation, but sometimes if you have open injuries, you have smokers, you have to not necessarily do what exactly is described in the book all the time. Complications from these fractures. Once again, main issue is having wound breakdown. This is a lateral extensile approach, and this is what can happen. Once again, you get about a quarter of your patients that have a wound breakdown, and about 80% of those end up needing surgical intervention. Post-traumatic arthritis, you can see of the subtalar joint. These can go on to malunions and non-unions. But the biggest thing, I think, again, for these fractures is the soft tissue injury and soft tissue breakdown. Any questions?